to that panel. Thank you all so much. All right, great. I'm going to have you guys take it over from here.
Testing. Greetings, everyone. I'm Nyabingi Kuti. I'm the director of the Los Angeles Harm Reduction Network, and I'm primarily a consultant in the area of addiction treatment policy in Los Angeles, in particular, in California in general. I feel like we're very far behind in policy, especially at the federal level, to advance access and improving access to addiction treatment. Buprenorphine and methadone is just such a disappointing policy. The policy around methadone, the more I dig into it, the more disappointed I get as far as how long it's been basically restricted, and the heavy counseling and supportive services that surround it, where other treatments aren't like that. And one of my main areas I'm focusing on now, I'm working on Skid Row in Los Angeles, which is experiencing a ravaging fentanyl overdose death epidemic. In 2017, there were 20 deaths on Skid Row in Los Angeles. And in 2022, there were 140. And this is primarily going unchecked. The black overdose death rate there is 53%, and Black women are 73% of the females overdosing there. So there's Blacks that represent Skid Row at the state level that I've been talking to, said, hey, you know, our people are dying on the street there. And one thing I like about this conference is that there's so many people that care here. And I'm just so disappointed to say that a lot of people in the Black community just really don't care. They don't go to Skid Row, the ones that represent Skid Row. The homeless encampments in their district, they drive by, and they say they're putting people into shelters and doing more, but the evidence is just not there on the streets. So also, I've been a consultant for the Drug Policy Alliance, and I work for Tarzana Treatment Centers. And I started seeing the high relapse rate and people that had been there 50 times. And I started asking the management, so are you doing anything different for these people that are coming here to frequent flyers? And they're saying, well, just get your paycheck and go home. And, you know, you're new to this. We've been doing this 30 years, so don't tell us how to do this. And primarily the reason they had that attitude is because there's a profit motive in treatment. And has anybody here seen Body Brokers with Michael K. Williams? That's kind of over the top with the treatment provider industry, but I recommend everybody see that because it really kind of awakens people to how the Affordable Care Act opened the door for more profits in the treatment industrial complex. So I'll move on and start with the panel here, introducing the panelists. We have Zoe Adams, and she's a graduate of the Yale School of Medicine and is currently working as a resident physician at the Massachusetts General Hospital. She has written extensively about the issues faced by people on MMT and increasing access to treatment. We also have Sharon Stancliffe. Well, you're a star. She has a long history of working in harm reduction in New York. In addition to her work in syringe exchange programs, she is the medical director, or she had a syringe exchange program as the medical director of a methadone program. She is also the previous medical director of the Harm Reduction Coalition and is currently the associate medical director of harm reduction in healthcare. No, it's what I'm looking at this last one. It's really interesting. She is also involved with international politics, including work in Ukraine and Tanzania.
That was a past. I meant to cross that out. I did it.
The past makes a difference.
Okay.
You did it. You did it. That's what counts. Okay. And then we have Joanne King. Joanne is the administrative director of Harlem East Life Plan, a multifaceted outpatient addiction treatment facility. She has a unique perspective from which to comment on the ways that race and other vectors of marginalization have impacted the ways that methadone maintenance treatment has evolved. And we also have Erin Ferguson, who also I forgot to mention, I came into this work with this coalition through the National Coalition to Liberate Methadone. There was an article in the LA Times about the lack of access to methadone on Skid Row, which is an opioid hotspot. And I reached out to Frances McGravy. I think it's Frances here. Frances. And she introduced me to Noah. And that's how I came into this work. And that's how I met Aaron. We've been on virtual calls together, and I've learned a lot from working with him. And yesterday I learned, I really appreciated your presentation, with your non-compliant presentation. That was very powerful. He is on the leadership team of the National Youth Survivors Union, the National Drug Users Union in the US. Aaron is an outreach manager for communications for Community Medical Services, a national methadone treatment provider. Aaron also produces a podcast called Narcotica. Okay. Okay. We got some fans out here. About drugs and the people who use them, as well as naturally compliant. So you have two. I don't like to explain that. I'd like to hear more about that. Yeah. A show by people on methadone. So I'll end here with the introductions and just jump in and let people start giving their presentation. So you want to start, Aaron?
Yeah, I'll jump in. Thank you so much for your kind words and for such an amazing introduction for all of us. I'm honored to be on a panel with these great minds. We really need as many minds thinking about this together as we can get from different angles, and each perspective is invaluable. So I just want to express sincere gratitude to you all for being here with me and with us. So yeah, I produce a show called Narcotica with Troy Farah, Chris Maraff, and Zach Siegel, and we've been doing that for a number of years, talking about, it's a show about drugs and the people who use them, and trying to change the media narrative about people who use drugs. I think we all know at this point there's something seriously wrong with the way that drug users and dealers are depicted in popular media. A lot of us can't even watch or suffer through the shows that exist on Netflix and HBO or wherever, just because there's just so much, just frankly shitty depiction of our people. And so the idea with that and with naturally non-compliant is to counter that narrative and The Naturally Non-Compliant is a sister podcast to Narcotica. The idea is generally there to tell the story of the patient that doesn't get to tell their story, and the patient that feels powerless, as many of us have, to do anything about the type of health care that we're receiving. We can submit a grievance and it goes into the ether and nothing happens. Or we can take the complaint to a counselor who is hamstrung to do anything about it. And we need to start shouting these stories from the rooftops, because I think if most Americans heard and knew about what people on methadone experience on a daily basis, they would be appalled. They certainly wouldn't want to put themselves through something like that. And they might understand a little bit better why so few people are going to treatment and why so many people are dying. So I worked on a piece this week, and the title was Methadone, the Miracle Molecule No One Can Get. And it's so frustrating, you know, as we talk about how we got here, it can be really hard to deconstruct how we got to the point where we have this answer at our disposal that could be saving so many lives. And for some reason, we can't seem to get it out to the public. And we clearly can do this when it counts. We did this during the COVID pandemic. You know, we can clearly mobilize public health to save people's lives when it counts, but we have to actually give a shit. And I think giving a shit is something that most of us will say that we do, but there are implicit biases that nearly everyone is running around with because of our conditioning through the media, through popular narrative, and most of the things that we've been exposed to throughout our lives. And I live with internalized stigma as a drug user. And it's a pretty safe bet that other people who don't use drugs have that as well. And what are we going to do about that? I hope that we can have a discussion a little bit today about how we got here. I think that understanding how we got to where we are is a critical step in untangling the mass of knots that is keeping us from doing everything that we could. And me and my people, our lives depend on this. We can't just take a day off or say that we're burned out and quit. You might not see us next time. So we got to figure this out, right? And we have each other. I just want to highlight that this group today and yesterday is a testament to the power of how an idea can grow in a very short period of time. It seems like yesterday during COVID that there were only a handful of us meeting on Zoom trying to figure out how to write a sign-on letter. And you know you're onto something when the idea grows itself. And that's not to minimize the hard work that's been done to bring this conference together, but we are really onto something when we see how many people have become involved with this and recognize it as a tremendous opportunity and a missed opportunity for the many decades that methadone hasn't been delivered in a reasonable manner. So maybe we can chat a little bit about how we got to this point, and I'd love to hear from the great thinkers on this panel about that.
Hi, everyone. I'm so happy to be here in my hometown city with so many of my mentors and people who I admire in the audience. So I can speak to the history of methadone treatment in the US, and I'm going to focus specifically on the Nixon era, President Richard Nixon, and how it's affected the way that methadone is delivered today. And so the birth of methadone treatment in the US can be tied to a very particular historical moment. In 1971, Richard Nixon declared his war on drugs. In doing so, he unleashed policies that criminalized substance use, that targeted communities of color, that invested heavily in our prison systems. And at the same time, there was a heroin epidemic that was affecting individuals, communities, soldiers returning home from Vietnam, a population that Nixon was very much so interested in. But in the same breath that he declared his war on drugs, he initiated an unprecedented endorsement and expansion of methadone treatment. And this is contrary to the popular opinion of like how Nixon is understood as a politician, right? Tough on crime, et cetera. But he was actually the president that said, hey, let's do methadone. It's a little bit more complicated than that, which I'll get to. But just for some context, from the 50s to the early 70s, 2/3 of the $750 million drug budget in America went towards strategies that targeted heroin supply reduction. But by 1974, 2/3 of this budget was then allocated to drug treatment and research. And in terms of methadone in particular, in 1968, there were about 400 people enrolled in methadone programs, but by 1976, the number shot up to 80,000 people. And Nixon's presidency was from 1969 to 1974. So this was all happening under Nixon. And so something I became really, really interested in was why Nixon in particular so readily embraced methadone as a treatment for opioid addiction. And I think there are a lot of answers to that question, but one thing I want to focus on today is how methadone was studied by physicians and researchers in the late 60s and early 70s, and how it was then packaged to the Nixon administration, other US government officials in general. So if I handed you a copy of like the New England Journal of Medicine, which is a prestigious medical journal from 1971 or 1969, whatever, and it was a study on methadone, you would see the big figure, the big graph on the paper is methadone and crime reduction. Okay. Methadone was shown not a causal relationship, but was shown to decrease crime. And that was study after study after study in my research. That was the thing that these studies were harping on, not patient preferences, not patient outcomes, not at all patient-centered, all having to do with crime. And the negative consequences of these studies was that people on methadone were labeled as potential criminals or potential criminals, rather than people experiencing an illness. And so Nixon ate up all of this data, and that's part of the reason why he really got behind methadone. And government agencies in the Nixon administration devised a way to regulate this medication that was completely unprecedented and the most regulated medication we have in America, which has not changed. And so that's exactly what happened. 1972, the Food and Drug Administration removed methadone from general distribution before doctors could prescribe it and people could pick it up in pharmacies. In 1972, that all changed. The opioid treatment program model was created, which we've talked about at length. It is carceral, it is surveillance oriented. And I think the thing, fears about diversion, methadone overdoses were used as reasons, justifications for why the regulations were so stringent. And we've talked a lot about diversion, yesterday, and I'm sure we'll talk about it more today. And I think the thing that bothers me so much is that fears about diversion and protecting community safety, people not affected by addiction, and crime prevention were really the things that these legislators and people cared about, not the patients in front of them. And that is still true to this day. Regulations have changed very little in 50 years, very, very little. And, Nixon is thought of as this president that ushered in the treatment era of addiction, but we have to think about it with, in a more complex way than that. It was treatment with strings attached. It's always been a system that has been more concerned about crime prevention than medical care and rehabilitation. And as we think about the future of methadone and policy changes going forward, this history, I think, needs to be really front of mind.
Wow, that was great. And I want to go a little further back, but first I actually want to acknowledge my relationship with Joanne. She taught me a huge amount of what I know when I was medical director at Harlem East Life Plan, where we tried, and now she has more opportunity with the changes, but we tried really hard to make the system kinder. And that is so hard. But somebody said yesterday about how come the programs can't be more patient friendly? I mean, one of the things we did, it's so simple, same day admissions. Don't throw people out for using drugs. I mean, those are such simple things, and it was hard to go further, but I can't wait to hear how it's going now. I want to add a little bit on to the history, or maybe go back a little further, because there's pieces to those early days that I think are kind of forgotten and really relevant to this group. When the originators of methadone set it up. I mean, they looked for other drugs to see if there was anything else that would help people stop using or feel better. They noticed with methadone, people like wanted to go and do something else because they were bored sitting around the lab. No, they didn't want to wait for the next dose. They wanted to go back out, and one was an artist and go places. So that was kind of the birth, is figuring out what the people at need wanted. And yes, you're right. It was so much within the criminal legal system, even in its early days. But these folks that developed methadone, Dole, Neiswander, Newman, Joseph, they hired their early patients as employees, as research associates. I mean, that's what we want now too. And in fact, I think maybe everybody's heard about the KEEP program at Rikers Island, the first incarceration program for incarcerated people to keep staking and get on methadone. That idea came from these research associates because they'd been there, done that. And in fact, the prison correctional officers couldn't figure out how they knew their way around the Tombs, the downtown jail, so well. It was because they had walked through as prisoners. So yeah, I don't want to forget that. These folks were incredibly brave to go up against whatever the DEA was called in those days to do this and make a treatment. It went a lot of bad places for sure. And you explained a lot of the reasons why. But one of the things that I watched over the years, I was with you. I mean, I started doing methadone in 1997. That's when we became involved. And as the problem grew among white affluent people, I would read all these articles about these white people that went into rehab after rehab after rehab, and they took equestrian therapy and beach therapy, and then died. And it just struck me as, this is crazy. There is this great treatment out there, but it is so stigmatized they won't go there because of exactly what you've said, is methadone was made for people that might be criminals, or it became that. It wasn't made for them. So I suppose that's kind of where the work on buprenorphine arose, which was being used some other places. And, you know, I admire the people that pushed that ahead too, but it really was touted as a drug for white affluent people. So much so it was like, well, it won't work for people that use heroin, especially if they shoot heroin. It won't work for people that don't have jobs. It won't work for poor people. I mean, that was really, I heard these things from doctors that were working on it. And I was like, gee, that doesn't really make any sense. I want to talk about the disease model a little bit later, but we're talking about molecules here. So one of my early projects at Harm Reduction Coalition was I got a little funding from the city of New York, and we started going to syringe exchanges to get people started on buprenorphine if they wanted to. And I was never, ever looking for people that were on methadone that try to convince them to change. Methadone might be the better drug. I don't know. Right now I can prescribe buprenorphine because of where I am, but methadone is an extremely good drug. But yeah, so I started having people that were not white, that, well, they worked hard, but they were not in the traditional economy, that had been shooting heroin. Some of them had been on methadone for a while, but it really didn't work for them. And I have my sort of biological theories about why that might happen. But people that were exactly the folks that they said buprenorphine wouldn't work for, it works. Some of them do better on methadone. One thing I hate about my job right now is if they're going to do better on methadone, I have to send them away. It's really frustrating, but when they need to go, they need to go. And I actually am really happy when I see some people that like, okay, this isn't working for me. I need to go somewhere else. But, you know, I still feel, and I admire the people doing the research saying, oh, look, buprenorphine works for homeless people, people with an experience in homelessness, because we need that research to convince people. But why wouldn't it? I mean, right now I work in a shelter, and that's who I prescribe to. And I have a whole bunch of people that now are housed, maybe employed, that keep coming back because they feel, I think because they feel safe there from the stigma. So I hope that paints some more of the picture of where we came to, of criminal justice. Oh my God, this isn't going to work for our people over here. So we need a new drug and we need more drugs for sure. I hope we continue with telehealth for buprenorphine. I hope that we liberate methadone in all the different ways we're asking for. And I think I'm going to turn it over to Joanne, but when it comes back to me, I'll talk a little about medical model.
Good morning. As I listen to everybody speak, so many things have gone through my mind. I am, as Sharon said, in East Harlem, day-to-day operation. You know, when I look out in the audience and I talk about the liberation of methadone, I first think about the liberation of the African and Latino community that's left there. They don't have the education to fall back on to say, I'm intelligent, I understand science, I could be a doctor, because their resources are limited. And when you go back to looking at an intention that was supposed to be good, which was the medication methadone, and how it first came about, years ago, there would be lines outside of methadone clinics, inside of methadone clinics. And it was just dehumanizing. And when you see the lines, you almost think of the lines when we got marched onto the boats, when we got taken off of the boats. And you have to think, what did that do to that soul? What happened to that person? So they was receiving a medication for a physiological need, but their mind was being all turned around and manipulated. It was disempowering. And when you look at treatment, treatment should be empowering. I should walk out the door feeling taller than I crawled in the door, if it's working. But the right people have to work it. The right passion has to feed it. And I think that it has to be a duality between the real world and the policy setters. And often there's a gap because they think they know what we need. And I mean, in good intention, but they really don't know the walk. They really don't know the talk. They really don't know the dance. And when you come into Harlem East Life Plan, that's what we try to do. If you want to hustle, you get to hustle. If you want to salsa, you get to salsa. If you want to crawl, you get to crawl. And it makes people want to come back. It makes people want to meet. It makes people want to greet. It was not a situation even prior to and now where you must get 60 milligrams. Because in very many communities, there was a myth that if you went up too high, your teeth was going to fall out. If you drank it and you stayed on it too long, you were really going to get fat. So people came in and all they wanted to do was take a chip off or whatever it was that they were doing. And if we met them there, then maybe we could take them to another place. But the conditioning had them themselves, the patient themselves, believing that they were not worthy, that they were not clean, that they were not in recovery, that they were not a good parent, that they were not a good face to represent and to stand up. So as we do these conferences, you know, we have to have more. We have to have more. We're saying liberation right now in East Harlem, still 40 years later, we're fighting with the community to determine and to understand the validity of what we do. They'd rather see every program wiped out. We don't want to see foot traffic. We don't want to see those faces. But those faces live in those buildings. Those faces shop in those stores. Those faces went to those schools. Those faces look like you and I. But the not in my backyard exists strongly in New York City as gentrification takes place. So we're moving forward. We're going to continue to go forward. But I think the history and the development and the way that it was introduced is having a strong impact on how we come out of it. I think that with conferences like this, with podcasts, with newsletters, it can happen. And it will happen, and it is happening. And I really impress on everybody that's here is that you step back and you look at yourself, you know, in terms of racism, sexism, classism, and how does all of that fit in? Because it's really not just about a medication. It's really about a human being. Would you ever think that if you had high blood pressure, you would have to tell them everything about how many people you had sex with, how many people you had kids with, are you still sexually active, how many ring piercings do you have just to get a blood pressure medication? And then you come back the next month, you tell the doctor, because your blood pressure is still high, oh, I didn't take it. So he said, okay, Joanne, that's okay. We're going to try again. But the methadone program, come back and don't be right. You may not have a slot. So we really need to understand, like Sharon said, not just from a social service perspective, but from a medical model, what it means to have a disease of addiction and how we treat individuals who have a disease of addiction. And is it culturally correct? The same thing. I got high blood pressure. I got diabetes. Don't eat beans and rice for dinner. Don't have fried chicken. But this is what I've been eating my whole life. So are you really going to be able to reach the person that you're trying to change their lifestyle, their cultural lifestyle, their dinner? Or are you going to try to help them manage the situation that may be negatively impacting their lifestyle? So as a front line, always want to be, and Sharon's saying, come on, clinician, I feel the need to be there to be able to say that I have a door that people can walk into as human beings, that people can touch each other, that people can find a place, regardless of their sexuality, regardless of their cultural beliefs, regardless of their race. They can find a home. And sometimes they get pissed at us, don't think, but they'll come back. You know, sometimes they don't come back and I just see them somewhere else. But as long as I know that they're okay, I'm okay. So I want to see this continue. I really want to be a part of it. I think it is awakening. And I think the history of methadone is important so that we can, as we get further in this discussion, really know where we are and where we're actually going.
Yeah, thank you so much. I learned so much from people doing this work and have the passion to make a change in society in regards to this issue of addiction treatment. And one thing that I think about often is who's really responsible for where we are with this lack of access or good quality treatment. And I go to what I call the Wizard of Oz, and that's the elected officials. Where are they? Where are any of their staff here? No? One. Okay, that's good to know. One. I think that they should be on this panel. And one of the things that frustrates me the most, and that brings me to this work, is that in California, the electeds at the federal level aren't sponsoring any of these MAT expansion bills. And we're supposed to be so progressive. And when I talk to these electeds, they say, yeah, I support that. And yeah, call me. And yeah, I'll get on it. And you call them and pretty much, yeah, they don't care. So are we opening it up to questions now? Anybody?
Well, I just wanted to say a little bit about the medical model just to piss off half the people in the room and make the other half happy. So when our panel met, one of the questions I was supposed to address was the intersection of methadone as medicine and as harm reduction. And I didn't think about it at first, but I realized that really brings me around to the medical model and what we call this. And a bunch of years ago, used to tell everybody they've got a disease and we're going to treat it. And it sort of worked with some people, but I realized at some point that calling this a disease, and I don't know what to call it exactly. I like OUD better than I like addiction, but I understand the problems with that. Increases the stigma, especially telling people they have a brain disease. So I've stopped using it. I mean, I have to use some of the terms OUD or people aren't going to know what I'm talking about, but it practically isn't an it, especially when we talk about all SUDs. But when we talk about people that use methadone and use opioids because they want to continue or they're compelled to continue, I don't think we're looking at a basket of apples. We're looking at apples, oranges, and pomegranates. I mean, some people, just yesterday, my youngest patient at the moment, 22, told me, yeah, I take my buprenorphine when I need some motivation. a whole bunch of other people take opiates because they have nothing to do, and having nothing to do makes it bearable. I don't think I see a lot of those folks in my shelter or at Harlem East Life Plan, but I think a lot of that has happened in our Rust Belt, where there's a lot of people using opioids because they have nothing to do. So it's a whole lot of different things. I like to say, well, I'm just a family practitioner, so I don't need to know exactly why something works. I just need to know it works. I don't know where to go exactly from a disease model, because we have to be able to talk together about things, but I'm not comfortable with that anymore as a way to characterize well, my little bias is I think there's an awful lot of really smart people that take opioids on a regular basis. I don't know if those two traits are tied together, but there's some old studies that suggest that. I think I like this work for a reason, because I like smart people. So I just wanted to say a little bit that we need to acknowledge that maybe that's not the solution to getting rid of stigma, and maybe it's not the only way to think about what people need moving forward.
Yeah, no, I really appreciate that. I appreciate you bringing that up, because I take umbrage to being told that I have a brain disease. I've been using opioids for most of my life. I've been on off methadone, on and off buprenorphine, and this doesn't strike me as something like that. What disturbs me is the way that I see the criminal justice system leveraging the idea of a hijacked brain, in which, if we go into the historical context of parens patriae, in which the court could act as the parent of a child in the stead of a child not having a caregiver. So these laws, parens patriae, are being applied to adults now. And Rebecca Tiger at Middlebury has written a book called Judging Addicts that really adequately deconstructs this sociological phenomenon, in which we are seeing people who use drugs as children. Our criminal justice system is treating people who use drugs as children who have hijacked brains. And there's a phrase that weaves its way through our criminal justice system that force is the best medicine. And so we get to have our cake and eat it too, because people who use drugs are sick and bad. So, right, because we're sick because we have this disease that hijacks our brains and keeps us from thinking for ourselves and making decisions. But we're also bad if we don't adhere to the probation requirements, to all the things that are placed on us. So it's kind of both, right? It's like, well, you have no control over your behavior, yet we're going to hold you responsible and punish you for not behaving in the way that you should behave. And so there's that dichotomy that's taking place throughout drug courts and throughout the country right now. And then it just really doesn't add up when you look at programs like the prescription heroin programs, in which you have tremendous outcomes. You know, you're basically taking someone who is chaotically using a substance, and their dose is going up and down. They don't know what they're getting next time they cop. And you're giving them that same substance on a consistent schedule of reinforcement. And now they no longer meet the criteria for a disorder. How could that be possible if the substance was the problem? If the substance was the problem, you couldn't give somebody that same drug and then see their problems go away. So there's this popular idea in methadone that it somehow normalizes the brain. And I know that that's been touted a lot. You know, the bad drugs screw your brain up and methadone would normalize your brain. I would posit that what normalizes people's brain is just having a life, just not living in chaos. And does it have to be this separate group of people who are a subset of society, or can we all examine our habits? I mean, a person is 30 times more likely to die riding a motorcycle than shooting heroin. We're not going out and screaming at people for riding motorcycles. You know, I just think that it's really hard for us to examine. I think it was Mark Twain said, nothing so needs reforming as other people's habits. And that's just true. It's always going to be that your habits are a disease and my habits are normal behavior. So can we take a look at that and start seeing people who use drugs as fellow human beings who are seeking pleasure and happiness just like everyone else and deserve the same right to survival, health, and thriving?
Oh, okay, there he goes.
This is an amazing panel. Thank you so much. My job is to read questions from the Whova app. So I have a question from Andrew Bell. How realistic are we as advocates collectively about where the level of public understanding is starting from? What are the best ways for us to set common baselines that anticipate basic misunderstandings about the overdose crisis, impacts of treatment on mortality, and persistent prejudice about methadone? That methadone is trading for one drug another. How do we dispel the stereotypes about liquid handcuffs, the nods, others, and integrate this into medical care? There's a lot of questions.
Just really quick, I want to add a point that I think will spark some discussion about that question. Okay, so who benefits from methadone is a question. I think is an important question. Like, who should be on methadone? And that's something that has been debated a lot. To me, whoever's at risk of overdose should be given access to methadone. And that doesn't even necessarily mean a person has to meet the criteria for a disorder in order to benefit from a safe supply, if that makes any sense. So we're talking about broadening the perspective about who could benefit from treatment beyond just the 10% of people who take an illegal drug that wind up meeting the criteria for a disorder, which is all based on social functioning. I mean, it's pretty damn hard to function socially if you're engaging in an illegal behavior. You talked about crime. Well, drug use and sales is a crime. So of course, if people stop selling and using drugs, crime's going to go down. But if people who just use drugs recreationally, like me and my people, are at risk of dying, doesn't it make sense to just think about it in terms of, okay, trading one drug for another, so what? I mean, we all make trades on a daily basis, and that's always done on the basis of the pros and cons. Every prescription that's given has a list of potential side effects, pros and cons, and those things are weighed. So why can't we start thinking just more rationally and reasonably about methadone?
Yeah, I think there's one question in the series of questions in terms of how do we get what is the general public's understanding of methadone in general, and how do we get people to where they should be in terms of the understanding? And I think if we walked out on the street here in New York City and talked to someone who had no one in their life who didn't experience methadone or addiction in their life, or no one in their family had that, and I asked them, what do you think about methadone treatment? Predominant response would be negative. It would be stigmatized. And I think that has a lot to do with methadone clinics as brick and mortar spaces, and the NIMBYism that Joanne brought up as well. And that is the predominant depiction in people's minds walking down the street of what a methadone clinic looks like, the lines. It certainly does not look like a medical space. The first time I went into a methadone clinic, I was a second-year medical student, and it's part of a big reason why I'm pursuing a career in addiction medicine and going to take care of folks who use drugs, because I went into that space and I said, this is not a medical space. This is not a medical space. This is a space that is carceral. And I was so deeply struck by that. And I think, unfortunately, the predominant understanding of how the response, to addiction is the abstinence model, 12-step AA, like that is still the one size fits all approach that I think most people walking down the street think you have to achieve. And how to change that, I'm trying to write as much as I can and tell stories. And will that work? I don't know. But I think if more people talk about methadone, get it out into in general audiences, et cetera, tell the stories, destigmatize it, I'm hoping public opinion will change. But we have 50 plus years of negative stereotypes and stigma to undo.
I just want to
Go ahead.
I just want to say quickly, when you think about the look, at all due respect, the New York State Office of Alcohol and Addiction Services really has begun to develop the clinics. Post-COVID, clinics are now accredited. And when you say looking like a medical office, I can speak for the partners that I do service with. The medical directors are there. Sharon was on the floor. I want to see my doctor. That's what they would say, because it's no longer a push-through situation. And now we have the uses of telehealth for methadone programs, and they feel good about it because they all got cell phones. Oh, call me. And all right, make sure you pick up. This is the time I'm going to call you. So it's about people being willing to come in to see the development, to hear the development. What you don't have in a city in New York is people to be able to say and still stand up and say, I'm a school teacher and I'm being maintained on methadone. Because if they say that, they might not have a job the next day. So we got to work on that.
And one thing I would like to see more data on is the efficacy of methadone treatment for fentanyl use. I've been hearing that it's showing very good results for fentanyl treatment, but I haven't seen any empirical hard data on that. So if anybody here.
There's some preliminary data that I've looked at. I'm on the research committee at the company that I work for. And the sample is over 18,000 patients in 11 states. And what we found is that 2/3 of people who test positive for fentanyl at intake are still using fentanyl after a year on methadone. Okay. And this hasn't been published. It's going to be published, but just think about that. Most people, most long-term patients on methadone are still using fentanyl. Okay. What does that mean about how we define treatment success?
Yeah.
What does that mean about the goals of treatment?
Right. They're alive though to be taking it.
Oh.
Right.
Hi, good morning, everyone, and thank you for this panel. My name is Raji Diathmangalam. I'm a senior policy social worker at New York County Defender Services. This is my first time at such a conference, and I come in and I want to have an open mind. And at the same time, I also am looking for the new ways in which I'll be proselytized. And so I'm sort of like thinking and listening. And I'm really appreciative of the comments that Director King made and also Dr. Stancliffe. For me, these are a few thoughts. Hopefully we'll deepen the conversation. So my postdoc supervisor used to say that if you have a car and you go to a mechanic, guess what he's going to find? He, she, they, guess what they're going to find? They're going to find something wrong with the car. So that sometimes our efforts to find solutions suffer from streetlight effect. We're looking for a solution here because that's where we think we know how to look. I wrote an open letter to District Attorney Alvin Bragg when he took office, saying that for any of us who are here in this room to some degree, I can't say for everyone, but perhaps to those of us who are doing okay enough in life, what we've been presented with is the prevention model, which consists of housing, financial and other security, and other kind of resources, quality resources to some degree. And C. Wright Mills has already written much about this in the sociological imagination. When we talk about brain disease or think about this as illness, I worked in a clinic in East Harlem, close to Marcus Garvey Park for years. And I spoke with patients. I spoke with, again, that term can have its own problems, but I spoke with people who came into the room, we closed the door, and what they were talking about, people from the community, were not about illness and disease. And yes, there's not that is also important to talk about. But often what they seem to present with was issues of soul murder, despair, and heartbreak syndrome. And I found that my social work education was simultaneously miseducating me to project my struggles and my challenges of navigating the system onto the people that I serve. Okay, my background before coming to social work is as a biochemist, and I say this for the next two comments I'm about to make. One is we often talk about random control trials. We all know that there's a selection bias in random control trials. The outliers are not the ones who make it into the trial. And every medical professional knows that the practice itself, in practice, is not within your Gaussian normal distribution, but it's often follows a idiosyncratic, meaning you're really looking at the person you're serving and looking at how to best fit those results onto them. And then the last thing I'll say is the thing about illness is about sociological implications. It's about food, shelter, clothing, vocation, education, being seen as a human being. And it's less about the neurobabble and psychobabble. Thank you very much.
Thank you. Thank you.
Another question from the Hoover app. How does the knowledge of the complicated history of methadone, Niswander and Dole, but also surveillance of Black and Brown communities help us liberate methadone?
I couldn't quite get could you do it a little more slowly? Yeah.
So the question is about how does the knowledge of the complicated history of methadone, what this panel has talked about, including work by Niswander and Dole, but also the surveillance of Black and Brown communities, how does all of this information help us liberate methadone?
Well, it helps us identify what policies we have to actually address and change. It helps us be able to recognize behaviors that can be, like I said, disempowering. You know, we had welfare reform, which is an example. And during welfare reform, if you were receiving public assistance, you had to go through a battery of these questions. And if they determined you needed treatment, not only did you need treatment according to them, they told you where to go. And they went to the so-called approved providers. Once you got there, then you had to tell HRA, I got here. And you had to have these things. But the deal was, if you didn't comply with what they thought you should be doing, you could lose your benefits, your money, your food, your this, your that. Welfare reform just kind of disappeared with the change of political parties. But in order to ensure that methadone develops and the punitive behaviors that they try to put upon it are addressed, we have got to be politically active. When he asked, where are the local politicians? Even when we do it in East Harlem, makes me feel kind of good because we at least get a representative here or there, that will come out and listen to us. But, this agenda has to be a mainstream agenda. It can't be a sidebar agenda. It can't be an afterthought. It's got to be real, it just the way it is. We have to be in the classrooms of the social workers being educated. We have to be there for the doctors who are doing their internship and they only want to go into Lenox Hill. They need to see what the reality is. That's what we can do.
And one thing that I think that we can be better, or there's room for action, is to have a dialogue with the OTPs. The OTPs are winning in this situation, and they're not here neither. And they don't, or maybe I'm wrong. Anybody from they're here. Well, I would like to hear more of their perspective on this issue because they're winning. And in Los Angeles, the OTPs that I have reached out to are not very interested in talking about this because they don't have to. They're making they're making the profit off of the way things are. So they don't want to see change. So if people that represent OTPs are in here, I think that they need to talk to us about that. Because I talked to somebody here yesterday that works for an OTP, and they agreed. Yeah, we should have more dialogue on things that we have in common. One thing I know that we have in common is that we would like to see more mobile access to methadone. I know that the office base, it looks like we're not really gaining any traction on that, but mobile access, especially, how do we not have access to methadone on Skid Row and Kensington and Philadelphia?
Yeah. Yes. And on that point about access, we have to look at the set of incentives and whether they're perverse or not for engaging with the industry of delivering methadone. And it's my position that, yes, there are financial disincentives to giving take homes, to providing less in-person services, right? There's a financial incentive to provide more in-person services. But I think if OTPs could realize that the losses associated with that could easily be offset by getting the 70% of people who could benefit from treatment who are not in treatment into treatment. You're talking about offsetting those detriments in those costs by many times over. So it's not an either or, it's not an all or nothing. If, as you said, we can take these innovative approaches to getting people into treatment that we know could benefit, that it could save their life, and keeping them in treatment long enough to really see the benefits from it, that we're then creating a set of incentives for doing the right thing that don't currently exist.
Can I just say, from state to state, things are different. But in New York State now, they have really fought for parity in that particular area. So even with telehealth, if I do a counseling session, via telephone, we don't even have to do face to face. It's the same rate as if the person was inside of the facility. They also are really working very hard to continue the staggered treatment schedules. So instead of someone coming in 6 times a week, even when they start, they come in as low as 3 times per week. And I mean, I think about it, the first thing I did when I graduated from high school was like Friday, Saturday, and Sunday is party. Who took a class on Friday? If you took that class, you were a real green freshman. So when you think about your life, to be tied into something 6 days a week, for how long? And then how long is based upon how well you present. Do you present? Are you on time? Did you give clean urine? Do you have an address? And it's just like, but honestly, for New York State, if you want to do business, I don't know who told you that, but it is now moving totally towards being patient-centered and harm reduction. If you believe in that, because people will take the jobs and they take out the piece that they want to develop and not the pieces that meet everybody's needs. So, New York State is moving. I knows that.
So thank you so much to all the panelists. My name is Lynn Taylor. I'm an internal medicine infectious disease physician working in an OTP, aka methadone dispensing business in Rhode Island for the last 8 years. Not one of the shiny academic patient-centered ones we've been talking about, but in a disgusting building. My old COO was here. She can attest to the shameful, disgraceful building should have been condemned. And I witnessed some of the horrifying, patronizing, dehumanizing experiences that have been shared here that break our hearts. But I just want to go back to what Mr. Kuti said at the very beginning about the treatment industrial complex and ask the panel, how do we get from methadone, Nixon methadone to this treatment industrial complex? It's really about these for-profit businesses, 3, Arcadia, a small number, strangling methadone. How are we going to move forward quickly if we don't expose, dismantle, blow apart the treatment industrial complex? And do we need to start with an expose? New York Times, Pew, what are these businesses? There's so few. What's happening with their CEOs? They're mostly, white, privileged people, maybe in Utah or somewhere. Yeah. And where's the expose? That was the case when I went to visit one program. I found the CEO was a billionaire almost in Utah. What about ATOD? I think ATOD is a wolf in sheep's clothing. The American Association for the Treatment of Opioid Dependence, pretending to be a medical caring organization, but really working to keep methadone unliberated in the hands of these OTPs, where many of us have been approached, come work for us. But guess what? You don't need any expertise. You don't need to know about this at all. Just come work for us. I'm interested in brain surgery, but no one's going to hire me as a brain surgeon. They want us to have no training because they can just say, here's what you're going to do. And then you start to wake up and think, oh my gosh, I can't believe what's going on here. And then when you start to speak up and say, this is really dehumanizing and horrible, then they want you out. So I'm just wondering, how are we going to move forward if we don't bust apart and break up the treatment industrial complex in ATOD?
Thank you so much for bringing that up again, because sometimes I feel like when I say things that they're not resonating. So thank you for saying that. And the answer, since you directed it to me, my answer is what I talked about earlier, and that's the Wizard of Oz, the politicians. We talk about SAMHSA, we talk about DEA, and all of these other organizations. The politicians can change that in the wave of a magic wand if they want to. We saw that in COVID. When they want to do something, they do it. When they don't want to do something, they'll set up a commission, they'll set up a bill, and all of our MAD access bills, where are they now at the federal level? Yeah.
Actually, I want to hear what Ayana's got to say for the last word.
Yeah, I'll be quick. This has been so good. I really like what Lynn was saying about blowing up. I do think this is where the media and writing, Zoe, to your point, could be helpful for the general public understanding what is happening and even knowing the term, the medical industrial complex. But I wanted to go back to what you said, Aaron, and I was just really thinking about this. I think this is why we need to have more Black and brown people in the discussions and in the leadership, because it can be really disempowering to use, like you were saying, why can't we replace one drug? Like, so what if we replace one drug with another? That's a big deal. You know, for Black and brown people, if I'm like, oh, it doesn't matter, you can, they're like, no, like my family is going to talk about me. I'll be stigmatized. Like I'm going to be an addict. The stakes are too high, right? So there are white women who can do things in NYU that I could never do, right? Because they're racialized as white women. So I think we have to be really clear when we are dealing with taking care of Black and brown people. Sometimes they can't have the level of freedom, not because they don't want to, but because society is going to treat them differently if the message is construed in one way or another. So I actually don't think for certain communities we can talk about it is replacing one drug with another, or who cares if it is. I think we have to be really clear, like you talked about with the data. If you take, when you are on this medicine, it can help you live a better life. And that is the discussion that needs to happen related to education and maybe allowing people who are teachers or whatever to be free and being able to talk, right? I also think there has to be some, I don't know if it's like I love Harlem so much. I live in Harlem. I'm glad to be there. And at the same time, I get so angry. Like there's great things that have come with gentrification. I can't wait till there's a Trader Joe's on 125th Street, right? But at the same time, I want the illegal vendors where I can get my Africana skirts, right? So I think that there has to be an innovative way, and I don't know the answer, to talk about the people who genuinely do not want OTPs in their backyard because they don't want to see people nodding out or crime or things like that. So I think there has to be a real discussion around, yes, where the OTPs are at, you're going to see people that, or things that you don't want to see. How can we talk about that freely? How can we have those discussions? So when I'm on my listserv on 123rd Street, they're not like, oh, they're going to open up an opiate prevention center. We can't let it happen. And I'm like, actually, we can let it happen. And these are the reasons. Like, how do we get people involved in those conversations in the way that it actually works? Yeah.
Yeah, thank you so much. Wow. I think that so much of this is just comes down to just do it and then see what happens after. Because if we wait until it's all the right conditions are in place and people are on board and then do it, you know, sometimes just doing something and the pushback that comes as a result of doing it is so productive. Like opening the first 24-hour methadone clinic in the country, there was a ton of backlash. There was a senator that tried to shut things down, but that broke into a conversation about it. Just the mere act of saying, hey, we're going to expand our hours to 24 hours. And patients will vote with their feet. I think to this question about what do we do about the OTPs and, you know, how do we get out of this system? If things are available, if I could choose, if I could say, well, I could go to Dr. A, Dr. B, Dr. C, and get the same treatment, which one is better for me? I'm going to make that decision that's in my best interest. And it's part of a broader discussion about safe supply, which I don't think we're ready to have as a country and as a culture yet, but it has to start somewhere. And what better place than methadone?
Yeah, I also think, Aaron, I agree, just do it. But I think the problem with that is it's not actually, it can just be done because the community pushback is so severe that places won't be cited overdose prevention centers will not be cited in Harlem because the community pushback is so fierce. We have one in Harlem, but other predominantly Black, brown communities in New York City. And so I really appreciate that comment and question, Ayana, because I think it also ties back to the history of methadone clinics and substance use treatment services and facilities have been predominantly cited from the beginning of their birth in Black and Brown communities in this country. And that is a form of structural racism that, you know, community groups in Harlem who have been there for a long time, that's the argument that they're saying, which is a valid argument. But it's not okay for the pushback to be that severe and the stigma, lots of stigmatizing language, again, substituting one drug for another, et cetera, et cetera. So it's a very complicated, I think it's more than just, you know, it's NIMBYism and et cetera, black and white, et cetera. I think it is a lot more layered than that.
I think one of the things that we have to do within our community is to make sure that we really put our pulse to the reality. Because when he talked about Michael B. Williams, and it's like, what happened? Was nobody there to say to him, we can help you, we can do this. It was years before he took his life. That was like years. And you say, and I see things like that and say, where did I miss it at? Where did I miss it at? Because you're seeing him on TV and you never would have thought. But what happens in white America is they don't miss anything. Magic Johnson was loved by everybody after he said he was HIV positive. He was endorsed 20 times over by the pharmaceutical companies. But let you and I say that. And anybody don't even offer her fork. Oh my God, you're going to her house? So we really got to get in there and educate not just the day-to-day people, but people in the athletic industry, people in the music industry, because it's going through there. Those kids are overdosing and those parents are having grand funerals and not letting anybody know. It's another secret that's put in the family closet. So we got to really work each other to really break down some of these myths and stigmas.
So I hate the part of my role that's cutting off these amazing discussions. I do want to give people a 10-minute break before we head to our next panel. So we're going to meet back at 11:35. Thank you so much to this amazing panel and moderators. Please ask your questions during the breaks and during lunch if you can.
So much for bringing up what you did, because it's been on my mind, and I'm glad you brought it up. Because I think, yeah, I think, and I also appreciate. I really I really want
I knew that you work at Project Mule, but I didn't know that part of your background that you were at Harlem.
Yeah, no, I've been several years and I decided to go, but harm reduction goal was.
So it was really great what you said about people.
Oh, thank you.